special guest.
When a person's diagnosed with cancer, so many aspects of their life are affected. That's why it's vital in survivorship care to seek to understand the whole person and the many ways that cancer and cancer treatment can affect quality of life. One of these areas that's incredibly important yet often goes unaddressed is sexuality. This is why I'm so pleased to introduce our special guest speaker tonight, Dr. Dizon, and kick off our program titled I'm Still Here, Ovarian Cancer, Survivorship, and Reclaiming One's Sexuality. Dizon is Professor of Medicine at Brown University, Director of Women's Cancer at Lifespan Cancer Institute, and Director of Medical Oncology at Rhode Island Hospital. He is a medical oncologist specializing in women's cancer and is the founder and director of the Oncology Sexual Health Responder Clinic at Rhode Island Hospital, devoted to men and women experiencing sexual dysfunction after cancer. He does research in many areas, including novel treatments, survivorship after cancer, and social media. He writes a column for the American Society of Clinical Oncology, FASCO, Connection, and the Oncologist Medical Journal, where he focuses on the human experience of doctoring in order to provide a glimpse of the physician as a person. He's active on several social media platforms, including Twitter, Instagram, TikTok. You have to see his TikTok, and is chair of digital engagement of the Southwest Oncology Group, SWOG, Cancer Research Network, a member of National Clinical Trials Network, funded by the National Institute of Health. Please join me welcoming the renowned Dr. Dizon.
I am very pleased to be here and really want to thank the Nixon family for the opportunity. You know, as a medical oncologist, you know, I do clinical trials and I see patients with gynecologic and breast cancers in Providence, Rhode Island. And it's with that perspective that I bring this conversation around sexuality to you. It's one of the least discussed areas in oncology, but it doesn't have to be. So for people who have cancer, but also for their caregivers, their partners, as well as their providers, I hope this will be useful. In terms of conflict of interest, I wish someone was paying me to talk about sex and cancer, but nobody is. So what I'm going to do tonight is characterize sexual health after cancer as it pertains to different types of malignancies, also describe the relationship between intimacy and intercourse, and then outline what there is available that we can do, which is bringing home the point that it's not just because I want to know what you're doing in the bedroom. It's not about being a voyeur. It's not about just hearing what you're doing. It's because we can actually provide evidence-based solutions to help you rediscover your sexual relationship if it's important to you. So here's a very typical person that I will see in this clinic. It's a 62-year-old woman. She had stage 3C ovarian cancer, and she saw me because she lacked desire. She was treated surgically. She got standard chemotherapy, and she was going on her second year without evidence of disease. She was being followed every 3 months by her gynecologic oncologist, and noted that pelvic exams every 3 months would provoke pain in her vaginal vault. She had been married for 30 years. So what do I do with something like this when they see me in clinic? First off, it's all about the history. You really want to talk to the person in front of you. What was sex like? What was your intimacy experience like before cancer? What was it like going through cancer as the person with it? What was it like for the person who supported you? What was it like as a couple? Have you tried to have intercourse? And what was that like? More importantly, if you think about the term intimacy, what does that look like for you now? So this is the deeper dive that we went through. She told me she regularly had sex once or twice a week, It certainly wasn't as often as they were younger, but it's something they really enjoyed, despite their older age. What was it like going through cancer? I never really thought about it. Surgery, recovery was rough, and then I had chemo. I still have neuropathy, and I've gained weight. I don't feel very comfortable in my own body. We tried sex a month ago. It hurt so much just to have him try to enter me. I had to stop, and he stopped too. He just didn't want to hurt me. What's intimacy like now? According to her, we talk and we hold hands. It's nice. For him, we are not close. I had to care for her during her cancer, and it's hard to be intimate when you've had to care for someone so sick. I guess it stops me. The take-home point after this is that cancer makes things complicated. It makes desire complicated. And it makes physical acts of intimacy very complicated. But it happens for very different ways. And it happens very commonly. So for people with gynecologic cancers, anywhere between 25% to 90% of people will have sexual dysfunction. And sexual dysfunction, the way I define it and the way Dr. Saeed defines it in her clinic, or Agarwal defines it in her clinic, is sexual issues that cause distress. So up to 90% of gynecologic cancer survivors will experience that. Breast cancer about as much, but it affects other cancers that are not sexual. Head and neck, 50 to 60%. Bladder cancer, 60% of people will have sexual dysfunction. Specifically focusing on gynecologic cancers, there is some data, but the data is limited. So this is what's called a systematic review, where they looked into the literature, searched through a couple of terms, and tried to synthesize the results. They found over 1,000 articles. They included over half of them. In fact, there was only 27 papers out of 1,000 where they could comment about the incidence or comment on how sexual function was after cancer. And only 17 of them gave them the prevalence, how common it is to have sexual dysfunction. And it was only involving 4 cancers: bladder, breast, colorectal, and gynecologic, which for anyone who has experienced ovarian, endometrial, cervix, vulva, vagina, those are not the same experiences. But for the purposes of this analysis, they were all lumped together as gynecological cancers. All of these experiences showed that using a standardized questionnaire, there was significant impacts on sexuality. And the lowest scores for sexual function wasn't in gynecologic or breast cancer. It was in colorectal cancer. If you look at female sexual dysfunction, or FSD, the prevalence was anywhere between 1/3 to 94%. And sexual dysfunction was the most common in people treated for gynecologic cancers. Not breast, gynecological malignancies. What we know is that it is also a long-term problem. It doesn't just happen when someone gets surgery and chemotherapy. It follows them for the rest of their lives. This is the Livestrong survey. It's about a decade old now. Most of these folks were white and educated who answered this question. But sexual function and satisfaction was a concern in over 60% of these folks. And in 1/3, it was a very big problem. But look at that last bullet point. Of those who said they had issues with sexual function, less than half ever brought it to the attention of their doctors. They suffered in silence with this, thinking They were alone. But the issue here is that sexual health is not about intercourse. Sexuality is a composite of multiple experiences for women. It's about intimacy and sensuality. It's about how they view their own body, arousal, desire, climax, and satisfaction. It's complicated. There's multiple things happening. So I ask this question to my colleagues all the time. After a diagnosis of cancer, sexual health, is it true that men and women experience changes in their sexuality the same way? And the answer is no, they don't. For men, we typically think this: it's either on or it's off. They either can get erections, in which case they also want to be intimate, or they don't. And this model has actually been borne out for people with prostate cancer. If I cause erectile dysfunction due to cancer therapy for prostate cancer, there's a very high likelihood that that man will withdraw from their partner. Because why go to first base if you can't go home? This is sexuality for women. It is far more complicated. Now, sit there thinking about you just starting your laptop or your desktop computer. You turn it on, it whirs, something appears on screen, and you're good to go. You don't think about it. But imagine if it ever happened to you, where you turn on the computer, it whirs, but nothing appears on screen, and then it just dies. That amount of anxiety, because you don't know what just happened, is very similar to what we do to people when we treat them for a gynecological malignancy. Because no one explains why you're sexual. You just are, until you're not. So what do you need to know about female sexual function? This is Rosemary Baston's model. I like this. It marries the biological functions, psychological functions, and social functions to help explore female sexuality. It starts here with intimacy. That's what wakes up the asexual person to wanting to explore someone in their lives. This signal of wanting intimacy wakes up the body, so that when parts are stimulated, you get aroused, and that arousal helps prompt desire. And when desire is satisfied, the circle propagates. Cancer, surgery, cancer chemotherapy, radiation breaks every single one of these arrows. But here's the thing, and this is the most important thing if you take anything away from me tonight. Desire and satisfaction, the link is not associated with any specific activity. It doesn't travel through intercourse. Unlike with men, where intimacy and intercourse are very tightly intertwined, that is not the same thing for women. So when you see your partner making dinner, or when you see him doing the dishes, and you get that sense of satisfaction and fulfillment and love, this is explaining that, because asexual, non-sexual acts can do as much as a sexual activity to promote satisfaction for the person who is just treated for cancer, especially if it was a gynecologic or breast one. So it's important that we ask about this, because there is data to show we can help. And the way that I want you to think about that is the things we can do to improve vaginal health, and the things we can do to improve sexual health. And these are two different conversations. GSM is genitourinary symptoms of menopause. For younger women who are not in menopause, getting treated for ovary cancer, uterine, cervix, or breast, that happens simultaneously. It is literally an off switch saying your ovaries no longer work. and it can be very dramatic. Vaginal moisturizers are crucial to recovery. It is part of routine health. It has to be applied on a routine basis, just like you take care of your skin and your hair. That is the same approach that I tell folks who see me in the sexual health clinic they need to take with vaginal and vulvar health. There are many types that are listed here. Polycarbophil base goes on the goes as Replens. Vitamin E can be used. You can even use natural oils externally. And then there's this parabens-free formulation called Luvena. Parabens is a very weak estrogen in the laboratory setting. And for folks who want to stay away from anything potentially estrogenic, this is an option. The instructions I give are not what's listed on the bottles. You have to use this 5 times a week, and you can reapply an hour before intercourse. But it's this kind of frequency that is required after cancer, especially if you were thrust into menopause. What about vaginal estrogen? Because this is a solution for people who do not get relief from moisturizers. Non-hormonal approaches should be used first, but for folks who do not respond well to non-hormonal therapies, vaginal estrogen is okay. This is much more of a controversy in breast cancer, but it's okay to use after cervix, ovary, as well as endometrial cancer. But we may have even a better solution for folks treated for a gynecological malignancy, and that's oral hormone therapy. Oral hormones, either estrogen alone, if you still have a uterus intact, or estrogen alone if you do not have your uterus, or estrogen and progesterone if you do, has been shown in randomized trials to be safe after a gynecological malignancy. It's not the same case in breast, in which case it is still contraindicated. But this is some of that data. So hormone therapy after breast cancer, we did a review, is in 2016. Over 1,500 women were included. There were 450 of those, or a third, who received hormone replacement therapy, typically estrogen only, because part of the surgery for ovarian cancer is removal of the uterus. Controls, no hormone therapy, in about 70%. Hormone therapy for ovarian cancer survivors was associated with a significantly lower risk of death from ovary cancer. That's over a 50% relative reduction in the risk of you dying of ovarian cancer without a difference in the recurrence rates. And there was no reported change in survival beyond that. This is another trial, the AHT trial, performed in the 90s, and it compared, again, hormone therapy to no treatment. And again, less people died of ovarian cancer if they were using hormones. Overall survival was improved, more so if you use estrogen only, and recurrence-free survival was also improved. So there is data to suggest that oral hormone therapy might actually help outcomes after ovarian cancer. Similarly, in uterine cancer, this is a study that I participated in, I think with Dr. Gordonier back in the day. It looked at early stage endometrial cancer. The study closed early because data came out from the Women's Health Initiative study showing that hormone therapy increased the rate of breast cancer. But that result was specific to combined hormone therapy. So estrogen and progesterone increased the risk of breast cancer, not estrogen only. So here, the intervention was estrogen therapy because most of these patients had their uterus removed. And what did we show? There was no difference in the proportion of people without evidence of disease. That's that first row. And very few folks recurred, with or without estrogen replacement therapy. 3-year overall survival was essentially the same. The relative risk of recurrence or death crossed 1.0 in this confidence interval, saying there was no significant difference in the recurrence rate. What about cervical cancer? This is a very old study from 1987 that looked at cervical cancer with drugs we don't even use anymore, but it was compared to no hormone therapy. And again, survival was improved with hormones after cervical cancer. In fact, the 5-year recurrence rate was numerically less with hormone therapy than it was without hormone therapy. So there's absolutely no data to suggest hormone therapy is bad after treatment for ovary, endometrial, cervical cancer. In fact, there's data in colorectal cancer showing the same thing. There's no high-quality data to inform the option, meaning using preparations we have today. But I actually have no problem giving oral estrogen to women treated for a gynecological malignancy. I think it makes sense to do it. There are caveats, and Dr. Gordon will tell you as well, because there are some gynecologic cancers that are hormonally driven, like endometrial stromal sarcomas, which are estrogen fed, like low-grade serous cancers of the ovary, which we believe are also estrogen dependent. But for the more common serous cancers of the uterus and ovary, cervical cancers, estrogen does not provide a disadvantage. What about testosterone? The reason we bring this up is because for people without cancer, it can improve desire after a hysterectomy for non-cancer related causes, if you become postmenopausal, and if you have a desire disorder, which I always find fascinating. So the desire disorder is everything works fine, you can have intercourse fine, orgasm is achieved, it's all fun, it's great, but after the end of the day, if I never did it again, that'd be too soon. Okay, so there's that, the feedback isn't working, but testosterone can help with that feedback mislink. But for people with cancer, is there enough data of a benefit to expose them to the eventual risks of aromatization? And this was answered in a clinical trial too, in the cooperative group context. It was 150 women. They were randomly assigned to testosterone versus a placebo, and they looked at sexual desire using a standardized questionnaire, and it didn't work. So in the first 4 weeks, you either got testosterone or placebo, and in the second 4 weeks, you had placebo or testosterone. They saw no difference using a standardized questionnaire. Now, one of the criticisms here is that you only gave it for 4 weeks. You should have given it for 12, and then 12, if you were going to see a benefit, because you probably masked it. This is the best data we have from a randomized trial. So for now, at least, I don't actually prescribe testosterone for folks who have a low desire problem. So what about treating for sexual comfort? Enough about the vaginal health, where the side effect of a good vagina is better sex. What can we do to improve comfort and pleasure? This is where lubricants come in, very different from moisturizers. They can be water or silicone-based, very limited data saying which one is better. One study suggesting they're about the same in women without cancer. The practical point is that silicone-based lubricants need not be reapplied as commonly as water-based lubricants, but they will stain your sheets. What about a natural oil? Some people don't want to use a chemical lubricant. Can you use olive oil? Can you use coconut oil? Experts in our field that Dr. Carwell and I practice in will say you shouldn't use them internally because there's a risk that they'll go rancid in the vaginal vault. That has never been reported, so it's hypothetical. There is one study in 25 people called the Overcome where they use olive oil during sex. And if you look here at the bottom, 73% of people really like that. So there's a case report out there, but that's all we have. There's also a phenomenon like the patient I presented where any attempt at penetrative activity causes pain. That prompts a physical exam. You must do a pelvic exam if you're having pain, because there are two types of pain. There's pain at the opening where someone will say, it's all going great, but when they try to enter, it's like flashes of light and it feels like knives are being drawn through. It's immediate. And then there's a pain that happens with thrust, where it feels like my vagina just wants it expelled. I just don't want it inside of me. It's just trying to squeeze it out. No matter if I try to relax or if my partner says to relax, it doesn't do it. Those are different, and they're treated differently. If there's pain at the opening of the vagina, there was a randomized trial that was done looking at aqueous lidocaine. That's water. It's a very dilute form of lidocaine. And what Martha Getch did was she took breast cancer survivors who on exam had vestibular tenderness, that's pain at the opening, and she randomly assigned them to lidocaine or a placebo. And look at this last line here. At the open label, 20 women who were abstinent, 17 of them were able to have sex again, penetrative intercourse, with aqueous lidocaine. And I can tell you firsthand, I love to diagnose vestibular tenderness because I can fix it the same day. This is what's required for someone who has pain with thrust during activities of penetration, when the vaginal smooth muscle is hyperactive. These are vaginal dilators, and they come in very different forms. This is the one I use. It's called a biotech dilator. It's silicone-based, but it also has this sort of head on it, as well as the shaft. And I think it more mirrors what anatomic penetration is like. My advice, and Dr. Carwell and I had a conversation today, use it in the morning if this is an issue for you. Because in the morning is when you're getting ready. It's usually the only time most people have to themselves. And it's the only time you're probably going to be the more motivated. If I ask you to use it at the end of the day, after you've attended a lecture, picked up your children, made dinner, relaxed, the last thing you're going to do is stick a dilator in your vagina. There are also drugs that we can use to treat interest and arousal. And this is a list of them and what the approval looks like from the FDA. So bremelanotide is a subcutaneous injection, flibanserin is oral. These are not female Viagra because you have to take them every day. And the more important thing is after you've been treated for cancer, it's unclear if you can rely on the results that led to the approval. For example, with flibanserin, you could not be on an anti-hormone, you could not be on an antidepressant, you could not be on an anxiolytic. Most people who've undergone treatment for cancer are on 1, 2, or 3 of those drugs. So what about intimacy? Because, I've said that men and women are different when it comes to intimacy. Intimacy is experienced in its own right for women. intimacy and intercourse are really an intertwined experience for men. The way I help to bring two people together, whether they're a same-sex couple or a heterosexual couple, is through sensate focus. What this is an intimacy exercise, and it divorces or it separates intimacy from sexual activity. Stage one, you're touching, you're stroking, you're kissing anywhere on the body. You start at the face, but the point is not to have intercourse. The point is not even to achieve climax. The point is to touch and to read each other. Stage two, you incorporate beyond just every other place on the body, but you specifically incorporate genitals and the breasts. Stage three, instead of one touching, then the other touching, you go to mutual touching. In stage four, you go ahead and rub against each other. What's important about that is it makes intimacy its own objective so that people can actually redefine their relationships on terms that they both want. And these are the rules of sensate focus. You touch, but you don't talk. You don't talk because it can be very distracting to be told what to do. You decide ahead of time about what cues one will use if things aren't going well. So it allows you to actually prepare for this, because one of the most important things is you don't want either of you to feel rejected. Okay? So you lay these ground rules together, and then you have this after moment where you actually discuss what it was like for you. What I ask people to do is tell me how often they can do this and when they're going to start. Because I've learned if I just give this a try it out, they won't do it. But if I say, this is your homework, so how often are you going to do this? And they say twice a week. When are you going to start? And then you see them back. And it's surprising that people will commit to this, especially if they're seeing me, because their sexual lives have changed after cancer. So what is your provider's role in all of this? It's important to understand why we don't talk about this. The first has been clear. There was a survey that Dr. Gournier and I did 20 years ago now about gynecological oncologists and their approach to sexual health. And it turns out we are doing so much already. We want to make sure you're alive without cancer. We want to look at your blood work and your CAT scans, and we have to prep for the next person who's coming in after you. So time is an enemy for us when it comes time to talking about sex. In fact, the clinic time that I've dedicated to this outside of my oncology practice, everyone gets an hour. Now, when was the last time anyone here with cancer had an hour to talk to their oncologist? It's a very different thing. But we also make assumptions, which are really unfortunate. We may look at someone as like, wow, she's 80, I'm not going to embarrass her by talking about sex. Or she's single, so I'm not going to make her feel bad, so I won't talk about sex. Or the disease has come back, it's metastatic, so I know all she cares about is staying alive, so I won't talk about it because it's too hard for her. So there's a bit of paternalism on our part, but there's also this sense that after, especially ovarian cancer, where the stakes are so high that you're going to recur within 3 years, if you make it to year 4 and you're complaining about sex, I'm going to look at you and say, my God, you're alive. That's amazing. But the final reason that we don't talk about it is, quite frankly, a lot of us are not comfortable talking about your sex life. It's like Pandora's box. I have no idea what I'm going to hear. So better not go there. But the clinicians need to understand that this is a very normal part of human life, that our sexual lives are what defines us as being human beings. And just like we talk about hair loss, bowel movements, neuropathy, we should be able to ask just the most general questions of every person we treat about their sexual life. It can begin by taking a sexual history. I'm going to ask you questions about your home life. You know, who lives at home with you? Oh, are you intimate? Do you want to talk about that further? That's it. The importance of that, and data has shown, if your clinician opens the door, they remember. And if they want to walk through that door in the future, they'll remember you had it open. And the final thing is, if you see or diagnose an issue, you can refer here at Norton to expertise. And that's important. So here are some ways that I ask clinicians to approach this topic. One is to ask for permission, not just go in gangbusters and say, you know, when was the last time you had sex? How was it? Did you orgasm? I mean, without context, it's very difficult. But if you ask for permission, you can go where the patient leads you. I would like to ask you a few questions about intimacy and sexuality. Is that okay with you? Some will say no. I'm here to talk about my cancer. Can I get chemo today? Then you provide limited information. Some women who are on aromatase inhibitors experience severe problems with vaginal dryness. I'm wondering if that's an experience you're having. Providing specific suggestions. I heard this lecture where they suggested maybe using a moisturizer might help. Is that something you want to try? And then intensive therapy is where you say, I'm out, I don't really know what to do next. Let me refer you to someone else. And it makes a difference. So I helped when I was at Massachusetts General Hospital. The bone marrow transplant program started a sexual health clinic for bone marrow transplant people. And if you look here, this is what male and female participants who underwent a bone marrow transplant were experiencing unknown before this. 90% of the men had erectile dysfunction, 30% had issues with intimacy, 75% of women had pain, and a loss of libido in 40%. Prior to having that clinic, 33% were not having any sexual activity, and after that clinic started, it dropped to 6.5%. We were able to show people who had a bone marrow transplant that they did not need to abandon their sexual lives, that did not have to be a sacrifice to their treatment. And when I was at Women and Infants Hospital with Dr. Gordonier back in the day, we had the Center for Sexuality, Intimacy, and Fertility. What I'm showing you here is that we were able to show that for people who showed up twice or more, we were able to improve their satisfaction scores and their ability to get aroused significantly. So you can actually change the trajectory of your patients and their loved ones by asking about sexual health. So in conclusion, what I think I'm hoping to impart on this group is that we need to communicate with our patients, and for patients, we need to communicate with our partners about what we are experiencing and what the cancer experience is like. Because if you can communicate those issues, we can consult others about what can I get, what can you do to help me survive this cancer better. Sometimes it'll take compromise. that for the couple where intercourse is not part of the repertoire, what can we do today? And that leads to clarity about what each person in a relationship wants, what they need, and what they hope for as they move forward together. Because after cancer, everyone deserves a sex life. That includes the young adult and the older patient. It includes patients already in relationships and those without a partner. It includes lesbian, gay, bisexual, transgender, and queer patients. And it includes our patients who are living with advanced and metastatic disease. But it also includes your oncologist. We all deserve this. It's a human experience. Because cancer is a social disease. Every patient with cancer, we are also treating their partners. So thank you so much for having me.
Say thank you so much for that illuminating, I think, just the talk that focused so much on quality of life, which I think is important. It's something that we all recognize as important, but it gives us tools for how do we actually get there. We should pause and take some questions. Does anyone have any questions for Don? Oh, is it a question?
Oh, thanks. Hey, early on in the talk you gave, thank you very much for this wonderful talk. Early on, you had a slide on a randomized trial, women with ovarian cancer, some of them took estrogens and some of them didn't. And you showed data that the ones who took estrogens lived longer. But I think, I might be wrong on this, I think there was another slide you showed that said there was no difference in the recurrence rate between those who took. Why are the patients living longer if there's no difference in the recurrence rate?
Yeah, so I think that's one of the, so the question was, I don't know if they repeat it, but why, if people are not recurring, why are they also living longer if there's no difference in the recurrence rates? So the problem with the cancer literature is that even though we might report survival, it's not cancer specific survivals. So it might be that, people live longer because they also exercise more, right? Or this was also a group that didn't take up smoking as much as the people who did not get estrogen therapy. There's so many things we cannot control when you're reporting overall survival, but it's unless you're specifically getting that data about causes of death, it's actually quite difficult to report cancer-specific survival.
Okay.
Yeah.
Thank you.
Anyone else? Anyone brave enough to ask a question?
I don't usually get a lot of questions, just so you know.
Is there anyone on Zoom? I know that we've got some people Zooming in. Where is she? Yes.
There's two.
All of a sudden.
Well, I'm a mental health provider, so I just wanted to compliment you on the discussion around not making assumption when a patient comes in, because I think the assumption's bidirectional often, that the patient also assumes if my sexuality is important, someone would have surely brought this up. It shouldn't be for me to bring it up to the provider. So I just wanted to make that comment, and thank you for that.
Thank you for raising that point, because it's so interesting, and I think Dr. Agarwal can speak to it as well. So many people come to see me in the sexual health clinic think that they're alone, because how often do you sit in a group with your friends and have these kinds of conversations, especially if all of your other friends have not had cancer? So there's a sense of isolation with sexual dysfunction after cancer. And I think one of the bigger things that I impart to people is when I say, it's very common. there's this weight that comes off, because all of a sudden they're being told, this didn't just happen to you. Yeah.
Thank you so much. That was a really great talk. I was just wondering how much you use somatic genetic testing results in your practice, especially, I think it makes sense with the high-grade serous patients, you can kind of blanket, provide HRT, but especially the endometrial cancers, and how much, especially the early stage patients, which is so common, and just how you incorporate the CARIS or Foundation 1 testing into your practice.
Yeah, I mean, I think we do it, particularly with the advent of PARP inhibitors in the maintenance context. We're sending these tests on tumor tissue now far earlier than we would usually, because we want to know, are there any options open for these folks? But I thought you were going to go with the genetic testing aspects of this, because I do not see BRCA carriers in my clinic. The folks who I see have a cancer diagnosis, but here at Norton, Dr. Agarwal does see folks with BRCA mutations in her clinic. And one of the questions that actually has come up, is it safe to give hormone replacement therapy to people with BRCA mutations, even though you remove their ovaries or maybe even take out their uterus, although that's not standard practice? Can you actually give them hormones? I mean, these are women who are taking their ovaries out at 30, maybe 40 for BRCA mutations, so they're being robbed of 10 years of natural estrogen therapy. So we did a systematic review, I would say about 4 years ago, and the totality of the data did not show an increased risk of breast cancer in people who had a BRCA mutation if you gave them hormone replacement therapy. Now, my plea for my gynecologic oncologist is, if you're going to do that surgery, and if someone doesn't want to bear children at the time of their ovary removal, I would like you to take the uterus as well. And the reason is not because there's an increased risk of uterine cancer, which I do not believe exists with a BRCA mutation, but it allows me to give them estrogen only, rather than estrogen with progesterone, which again, in a randomized trial, compared to placebo, increased the risk of breast cancer.
Treatment technology is followed, and what new technologies are coming into force
For sexual health?
for cancers of this kind?
So, I mean, I think if you look at, I'm not sure if I understand the question correctly, but there's clearly a bunch of advances in the treatment for ovarian cancer, which Edie Nixon did comment on, that shows that we are helping our folks live longer lives. When it comes to survivorship and sexual health, there's been a lack of progress, I'd say. I wrote a randomized trial to look at one of these drugs called flibanserin in cancer survivors with very open inclusion criteria. So you could be an antidepressant, anxiolytic, anti-estrogen with this drug. And it was not approved to go forward by the National Cancer Institute. But I think we need that information. There's some work in improving the options for dilators and vibrators. But the problem there is that they're not doing it with a scientific lens. They're doing it with a commercial application, so that they're going direct to consumer without the data.
I had a question from a psychosocial perspective, and with your clinical expertise, and then I also know we have some psychosocial expertise in the room. From my time being an oncology nurse, especially when I did patient education, I saw anecdotally a high rate of marital separation and divorce. And I was just curious if there was any research that tied that to sexual intimacy issues.
You know, I can't point to data-driven studies where people were asked why they were separating and divorcing from their spouses. So I don't know the answer to that, but I would 100% agree with you about your anecdotal experience seeing that happen. I know in my own clinical practice, I don't know if Layla, if you want to comment too, but there are folks who have seen me after the fact of the divorces when they're meeting new partners, and it's usually this lack of communication about what just happened. You know, there's this thing that happens more often in breast, not so much with gynecological malignancies, where I think we set people up, especially it's early stage breast cancer, maybe triple negative, maybe they got chemotherapy. Well, we say, we're gonna give you this much treatment, and then you're gonna be fine. We're still gonna need to watch you, but you're gonna be fine, we're treating you for cure. The way the person with breast cancer hears that and her partner hears it are very different.
Yeah.
So a partner will hear, after that last chemo, after that last radiation, you're done. We're gonna celebrate, we're gonna go to a nice hotel, and we're gonna be intimate, and we're gonna go back to the way things were. But the person who just went through that cancer realizes there's a scan waiting for them in 3 months, or a mammogram waiting for them in 6. There's the fear of recurrence that lasts for years. And she realizes it's never over. But we don't give space for that conversation. So I think without services like we have here at Norton, without the service we have literally across the country, we can't help couples repair. You know, because we've never provided them with the language to have that conversation or even the space. Yeah.
I'll comment on that briefly. I thought that was an excellent comment, and I think you've said that in a really eloquent way. Often support systems don't understand people need care and support after cancer. People kind of fizzle out. I'm really getting ready to read the online questions, though, so I'll do that now. So the online question is similar to your BRCA conversation. What are your thoughts on HRT for ovarian cancer survivors with Lynch syndrome?
Yeah, I think that's a really important question. I'm actually okay with it because we have separate data on HRT in colorectal cancer survivors. Now, you know what I think what's the most interesting about Lynch syndrome, especially for women, is that it is not uncommon for people with Lynch syndrome to be diagnosed after they've been diagnosed with uterine cancer. You know, we have several cases of, unfortunately, people who are getting their colonoscopies because they knew they had Lynch syndrome, but they weren't seeing the gynecologist because they only thought they were getting colon cancer as part of Lynch. But for folks who've survived uterine cancers, especially high-grade uterine cancers, I think hormone therapy can be discussed and offered. The caveat is a lot of people, after they've been treated for cancer, don't want hormone therapy. I'm not the person to convince them they should get it. So I still leave space for people to say, what else can you do that's not hormonal?
And thank you for your talk. It was really good. It's a topic that is near and dear to me as a gyn-onc as well. In your practice, whenever you have a patient that you've started on oral estrogen therapy and they feel that it is not beneficial and they don't mind continuing or not, do you advise them to stop or to continue that therapy? And what is the most common reason that you find outside of, you know, the obvious contraindications that you found that, okay, I think it's time to stop that estrogen therapy?
Yeah, I think that's a really great question as to what prompts people to discontinue. One of them is exactly like you said, you know, it's like you said this was going to do this and this and this, and it's not working. So I think part of it is the expectations people have over a medication that's supposed to help their quality of life, and it doesn't do it. And then they're often not asking me if they can come off of it, right? They're stopping it, they're letting me know later that they've stopped it. I always suggest maybe give it another trial if it's been a short amount of time, So if they've only been on it for a month, I might say, let's try it for a couple more months. I'll see you in 12 weeks rather than in 6 weeks, 2 more weeks, give it 2 more weeks and then we'll try. Let's see you in 12 weeks and see how you're doing. So that's usually what it is. If it's a short amount of time, I'll ask them to continue. If at 12 weeks though, they really haven't felt like it's helped at all, I'm okay with them discontinuing it, and then we'll search for a different solution. So, lack of efficacy. But the other thing I think that happens is that, we live in communities, and oftentimes cancer and hormones are not mentioned in the same sentence. So oftentimes they'll get the pushback as like, this is not safe from a relative. It's like, you're going to get breast cancer if you take this hormones. What are you doing? You just had ovary, And so there's that level of, societal scaring that happens. And the third is, it's an interesting one, but my friend Ann Katz wrote about this. Pharmacists sometimes will not prescribe it for people treated for cancer because in their determination, it will increase their risk of recurrence. Now, it happens more commonly with hormone-positive breast cancer, and it's only happened to me once in 20 years. But, our colleagues need to act on their own conscience, and oftentimes their conscience tells them you shouldn't be on hormones after cancer. And then it takes a phone call from me to say, what is your understanding of this whole thing? And then literally re-educating them with data that what their perception is not correct.
Can you share anything about bioidentical hormones like pellets?
Yeah, so the thing about bioidentical hormones is that it's an unregulated industry. So back in the day, I tried to do a clinical trial. Actually, Mary, you were around. I did this at Women and Infants using a tea called SEAC. And I want to test SEAC tea for quality of life advantages. And the FDA made me put them into pellets and make sure the quality of the pellets was similar. And this was a very expensive process. That's not the same thing that happens with our nutrition industry or our vitamin industry. So the consistency of what you're getting is never clear. And that makes it very difficult to conclude anything definitive about safety and efficacy. It's very unclear what's in those GNC pills that you're taking that are called bioidentical. I think the closest thing I would probably say is, in terms of the food industry is more regulated than GNC and nutrition. So soy products, for example, in the US don't have nearly the same composition as the soy in Japan. So the estrogen content of the US soy is far, far less, never been associated with an increased risk of relapse from breast. Yeah. And I'm not sure how effective it is either. Okay. All right. I think we're done.
All right, well, I would like to once again thank the Norton Healthcare Foundation and the Nixon family for their generosity in making this night possible. Everyone drive safely on your way home. Good night.